Welcome to Roadmap to Residency. Today we are diving into pulmonary embolism for the Step 2 Clinical Knowledge exam. This is not a full topic review. Instead, we are focusing on test-taking strategies and high-yield question stems you will encounter on board exams. If you want to learn the full pathophysiology and clinical details, check out First Aid in your preferred question bank. Let's get into it. Here are our learning objectives for today. We need to master the Wells criteria because boards love testing your ability to risk stratify patients. You must know when D-dimer is appropriate versus when to skip straight to imaging. And critically, you need to differentiate stable versus massive pulmonary embolism because the management is completely different. For the deep dive on these topics, refer to First Aid and Pathoma for the foundational concepts. The Wells criteria is your framework for every pulmonary embolism question on boards. Think of it as your decision tree. Low probability, meaning a score of 4 or less, is when D-dimer becomes your friend. A negative D-dimer rules out pulmonary embolism in these patients. But here is the key test-taking tip. When boards pile on risk factors like recent surgery, cancer history, and leg swelling, they are pushing you toward high probability. In high-probability patients, D-dimer is useless because it will often be elevated anyway. Go straight to computed tomography pulmonary angiography. Let's memorize the Wells criteria point values. The 3-point items are clinical signs of deep vein thrombosis and pulmonary embolism being the most likely diagnosis. The 1.5 items are heart rate over 100, previous venous thromboembolism, and recent surgery or immobilization. The 1-point items are hemoptysis and active malignancy. You do not need to memorize exact cutoffs for boards, but you must recognize patterns. Multiple risk factors equal high probability. Let's work through this classic board question. We have a woman with sudden dyspnea after a long flight, tachycardia, hypoxia, and a swollen calf. Stop right there. This is a classic presentation loaded with risk factors. Before you even calculate the score, you should be thinking high probability. Let's walk through the answer choices. First, calculate the Wells score. Deep vein thrombosis signs give us 3 points. Pulmonary embolism being the most likely diagnosis is another 3 points. Heart rate over 100 is 1.5. Immobilization from the long flight is 1.5. Total score is 9, which is definitely high probability. Answer A, D-dimer, is wrong because you only use D-dimer in low probability patients. Answer B, computed tomography pulmonary angiography, is correct because this is the gold standard for high probability patients. Answer C, ventilation perfusion scan, is reserved for patients who cannot receive contrast. Answer D, lower extremity Doppler, may confirm deep vein thrombosis but does not diagnose pulmonary embolism directly. The key insight is that when boards stack multiple risk factors, they want you to go straight to imaging. Now let's talk about when D-dimer is appropriate versus when to skip it. D-dimer is useful in low probability patients. Typically young patients without obvious risk factors, where the goal is to rule out pulmonary embolism. But skip D-dimer entirely in high-probability patients, post-operative patients, cancer patients, and pregnant patients. In these populations, D-dimer will often be elevated anyway, making it non-diagnostic. For imaging, computed tomography pulmonary angiography is the gold standard. Ventilation perfusion scan is for contrast allergy or renal failure. In pregnancy, ventilation perfusion may be preferred to minimize radiation to the fetus. Here is our second practice question about anticoagulation. We have a stable patient with confirmed pulmonary embolism. Normal blood pressure, reasonable heart rate, no contraindications. What do we give them? Let's analyze this question. First, assess stability. This patient has normal blood pressure and is hemodynamically stable. This is not massive pulmonary embolism. The boards want you to recognize stable pulmonary embolism management. Answer A, unfractionated heparin is acceptable but not preferred in stable patients without renal failure. Answer B, tissue plasminogen activator is wrong because thrombolytics are reserved for massive pulmonary embolism with hypertension. Answer C, rivaroxaban, is correct because direct oral anticoagulants are now first line for stable pulmonary embolism. Answer D, warfarin alone, is wrong because warfarin requires a heparin bridge and takes days to work. Answer E, inferior vena cava filter, is only for patients who cannot receive anticoagulation. Here is your anticoagulation management summary. First-line therapy for stable pulmonary embolism is direct oral anticoagulants like rivaroxaban or apixaban. No bridging required. Boards favor these for stable patients. Special populations require different approaches. Cancer patients should receive low molecular weight heparin. Severe renal impairment requires unfractionated heparin. Pregnant patients need low molecular weight heparin because warfarin and direct oral anticoagulants are contraindicated. For duration, provoked pulmonary embolism with a reversible risk factor gets 3 months. Unprovoked pulmonary embolism often needs indefinite therapy. Now for our third practice question on massive pulmonary embolism. This patient is post-operative, suddenly unresponsive, hypotensive with blood pressure of 70/40, and has right ventricular strain on bedside echo. This is a completely different scenario. Let's recognize what is happening. This patient has massive pulmonary embolism by definition, hypertension with systolic blood pressure below 90, right heart strain on echocardiogram, and cardiovascular collapse. Mortality is extremely high without aggressive intervention. Answer A, computed tomography, pulmonary angiography, is wrong because you do not delay treatment in an unstable patient to get imaging. Answer B, tissue plasminogen activator, is correct. Thrombolytics are life-saving in massive pulmonary embolism. Answer C, heparin alone is insufficient for this degree of hemodynamic compromise. Answer D, rivaroxaban, has no role in acute massive pulmonary embolism. Answer E, emergent surgical embolectomy, may be considered if thrombolytics fail or are absolutely contraindicated. The key is recognizing the unstable patient and acting fast with thrombolytics. Here are your key test-taking strategies. First, risk stratification is everything. Count the risk factors in the stem. Multiple factors mean high probability, which means skip D-dimer and go to computed tomography pulmonary angiography. Second, hemodynamic status drives management. Stable patients get anticoagulation with direct oral anticoagulants. Unstable patients with hypertension need thrombolytics immediately. Look for right heart strain on echocardiogram as a board buzzword for massive pulmonary embolism. For more practice, review the pulmonary embolism sections in first aid and your question bank. Thank you so much for watching. If this video helped you, please hit that like button and subscribe to our channel for more board-focused content. And if you need personalized tutoring or guidance on your residency application, visit our expert tutors and advisors at roadmaptoresidency.com. We are here to help you crush your boards and match into your dream program. Good luck with your studies, and we will see you in the next video.